Well, welcome everyone to the March Survivorship Lecture Series. This morning, I'm excited to bring in Dr. Anna Chichura. She has a wealth of experience, having trained at Georgetown University, the NIH, the Cleveland Clinic, North Shore, and University of Chicago. She practiced breast surgical oncology and benign gynecology at the Cleveland Clinic and is a certified menopause practitioner. She's an active member of several professional organizations and has received multiple teaching and research awards. Just starting here at UIC recently, Dr. Chichura is a breast surgical oncologist and benign gynecologist and the director of the OB-GYN Hereditary Breast and Ovarian Cancer Program, where she'll foster collaboration between departments in enhancing the hereditary cancer program at UI Health. But today she's going to speak with us about breast surgery for survivors and previvors. Go ahead.
Thank you so much for the invitation to talk today and for the really nice introduction. So as you mentioned, I'll be talking about risk-reducing mastectomy for breast cancer previvors, although a lot of the surgical options and reconstruction definitely apply to cancer survivors as well. I don't have any disclosures. When we think about breast cancer, we know that breast cancer is the most commonly diagnosed cancer in women and the second leading cause of cancer death in women in the United States. There are several different breast cancer risk factors, some that are non-modifiable or things that we can't change, and some that are modifiable. Modifiable things tend to be more lifestyle related, non-modifiable things being like the sex that you're born, um, increasing age, family history. And then today we're going to be focusing on known pathogenic variants as one of those risk factors. There are several genes that can be inherited that predispose to breast cancer. We commonly think of the BRCA1 and BRCA2 genes, but there are several others that also increase that risk. And thinking about the prevalence of BRCA1 and 2 pathogenic variants within the US population, we know that approximately 1 in 400 people in the general population carries one of these genes, which turns out to be about 850,000 people in the US. When we look at specific populations, that turns out to be about 1 in 40 patients in the Ashkenazi Jewish population, 1 in 10 women with breast cancer, and almost 1 in 3 women with breast cancer under the age of 40. And while we think of these genes as occurring in particular populations like the Ashkenazi Jewish population, as I mentioned, actually the most common ethnicities that we see them in are in African patients of African descent, as well as those from Latin America. But overall, it's relatively equally distributed across several ethnicities. Um, Traditionally, we think of the BRCA genes as being associated with breast and ovarian cancer, although they can be associated with increased risk of other cancers like pancreatic cancer, prostate cancer, melanoma. But in looking at the lifetime cumulative risk of breast cancer for BRCA1 and BRCA2 pathogenic variant carriers, the risk of breast cancer approaches 70% by the age of 80. And the risk of ovarian cancer for BRCA1 carriers approaches 40%, and approximately 20% for BRCA2 carriers. When we're thinking about options for patients who have one of these genes who are at high risk for breast cancer, there's several different things that in general we can counsel them about. One being surveillance, including things like physical exam, mammogram, and MRI. We can talk to them sometimes about chemoprevention or medications to reduce the risk of breast cancer. And then also, we will also often discuss risk reducing surgery, which is again the focus of this talk. The current NCCN guidelines recommend that we discuss the option of risk-reducing mastectomy for patients who carry a BRCA1 or BRCA2 pathogenic variant, CDH1, PALB2, or those who have Cowden syndrome, Peutz-Jeghers syndrome, or Li-Fraumeni syndrome. There are other genes for which there's currently insufficient evidence to recommend or consider risk-reducing mastectomy, but instead these patients should be managed based on their family history. So if they have a strong family history of breast cancer in one of these genes, it may make more sense to do risk-reducing surgery as opposed to someone who has one of these genes that doesn't have a history of breast cancer in their family. The other thing that's important to note is that when we get genetic test results, only those that are come back as likely pathogenic are clinically actionable or things that we should be operating for as surgeons. Um, but several different results can come back from the results of genetic testing. It can be either benign or likely benign. Um, there can be variants of uncertain significance, the majority of which are reclassified as benign. And then again, the likely pathogenic or pathogenic. And so the big sticking point is that we don't want to be offering these surgeries for patients with variants of uncertain significance. There are several key counseling points for risk reducing mastectomy, including the degree of protection that a patient would obtain from surgery, surgical and reconstructive options, the risks of surgery, um, reviewing their family history and what the residual breast cancer risk would be, and the different psychosocial and quality of life aspects of risk reducing mastectomy. We'll start first with the degree of protection. We know that there's approximately 90 to 95% relative risk reduction. So if we're looking here at a population of 100 women who have a lifetime risk of approximately 70% of developing breast cancer, after surgery, there's a residual risk of about 1 to 3%. So it's important to counsel patients that it's not a guarantee that they won't develop breast cancer, but the risk is significantly reduced. There also appears to be more evidence that there is a breast cancer specific survival as well as overall survival benefit for patients with a BRCA gene who undergo risk reducing mastectomy. And when you look at each gene individually, it appears that that overall survival benefit may be more biased towards those with BRCA1 genes as compared to BRCA2. And moving on to surgical and reconstructive options. When I talk to my patients about mastectomy, I always tell them to think about the breast as being a pillow in the pillowcase. And my job as a breast surgeon is to remove the pillow and leave the pillowcase. And then the plastic surgeon comes and they put in a new pillow. And for those who choose not to get reconstruction, we just leave, we remove any extra pillowcase that might be there so that it's smooth and flat. Um, so again, moving now to actually thinking about the surgical procedure itself, for mastectomy, I'm going to focus on those who undergo reconstruction and different options for mastectomy um, with reconstruction. So traditionally, mastectomy with reconstruction would be performed as a skin sparing procedure where the nipple would be removed. So you can see on the right hand side here, or left hand side, this was pre-op. And then on the right hand side, post-op, these women do not, they kept the skin envelope from the breast, but the nipples were removed. And generally, this is an option that we need to offer to our women who have ptosis or sort of where the breast and the nipple hang below the inframammary fold. Um, and then for those who do have skin-sparing mastectomy, it is possible to perform nipple reconstruction, like this photo in the bottom right corner here. There's several different ways that the nipple can be reconstructed. One is using their own tissue to form a 3D version of a nipple. Another option is to perform a nipple tattoo, and that can either be a temporary tattoo or a permanent tattoo. And there's also nipple prosthetics that women can get that are waterproof and they stay on for a couple of weeks, actually. What we've moved towards more for women who are candidates for it based off their anatomy is a skin and nipple sparing mastectomy. So for this type of mastectomy, often we'll make the incision underneath the breast. And then you can see how cosmetically the before and after photos, the breast looks very similar to what the preoperative aesthetic was prior to the risk reducing surgery. For women who do have ptosis or breasts that are larger where the nipple is below the inframammary fold, it is possible to perform a reduction where we move the nipple, remove some of the breast tissue, move the nipple up to a higher position and make the breast overall smaller. And then you can go back later and do a skin and nipple sparing mastectomy later so that they can still preserve their own nipple. This really begs the question, does nipple preservation actually matter? Um, we found that women who have a skin and nipple sparing mastectomy as compared to those who and keep their nipple compared to those who just have a skin sparing mastectomy, they tend to have more satisfaction with their breasts, more satisfaction with their postoperative outcome, better sexual well-being, and they don't have any increase in cancer-related distress or perceived breast cancer risk, nor do they have a difference in decision regret. The next question that this begs, though, is it really safe to keep the nipple? So this study looked at 548 women who underwent skin and nipple sparing mastectomy, and they did not see any breast cancer diagnoses in a 3-year follow-up period. A more recently published prospective review of patients with BRCA1 and BRCA2 pathogenic variants found 5 cancers in a follow-up period of 6.3 years, 4 of which were in the skin and nipple sparing mastectomy group. They did not feel strongly enough to recommend against skin and nipple sparing mastectomy. At this point, it's still felt to be safe. But really, when we're thinking about it, a lot of the risk comes to how thick the skin flap is. So when we're looking at the cells that actually make up the nipple, the risk of cancer comes primarily from these columnar cells. And as we move up to the cuboidal cells here in the squamous cells, there's not the same risk of cancer developing in these cells. So as a surgeon, I need to get very close to the nipple here while also maintaining the blood supply to the skin here so that the skin can be preserved. Okay, so refocusing now, we're back mastectomy with reconstruction. I'm going to talk about different types of reconstruction. So reconstruction can be performed using the patient's own tissue. So something like a deep flap or a tram flap, moving tissue from their abdomen or from their back up to the breast. Or it can be performed with an implant, and that implant can either go behind the pec muscle or in front of the pec muscle. There's also different types of implants, those that are made out of silicone and those that are made out of saline. And then sometimes women either who have breast cancer or who have different type of mastectomies who are not happy with their current size will have a tissue expander placed. And so I just have a brief video to show that. But basically the tissue expander is behind the skin, and then it can be filled with the needle to help stretch the skin slowly over time. So this would be over the course of several weeks. And then later, the tissue expander would be removed, and then the patient could undergo either autologous reconstruction with a flap or an implant-based reconstruction. Another thing that's sometimes offered to patients as part of reconstruction is fat grafting. So essentially, they would undergo liposuction from their abdomen or thighs or buttocks, and then that fat would be prepared and then re-injected. So often this will be done for women who have a really sharp demarcation between their implants and where the skin is. And so here you can see where in the drawing, they sort of use the fat here to fill the upper pole of the breast. You can see how this is smoothed out compared to this other side. Moving on to mastectomy without reconstruction, the first thing that we would typically talk about would be an aesthetic flat closure. And the goal for that is to have the skin and the chest wall be smooth without extra dog ears or pooching or extra skin. And so there's a really great group called Not Putting on a Shirt that has a directory of surgeons that offer flat closure. And unfortunately, some women have experienced what's referred to as flat denial, where on the left side here, you can see that these women asked for a flat mastectomy closure, but for whatever reason, their surgeon did not honor that request and left extra skin behind if they were to change their mind, that they wanted reconstruction. So you can see comparatively on the right side how the chest wall is smooth and flat after surgery. For women who don't undergo reconstruction, there's different options for breast prosthetics that can be used, as well as post-mastectomy bras. And then another option for women who decide to have breast surgery without any sort of reconstruction is what's referred to as a Goldilocks procedure. So if we think of Goldilocks and the three bears, we're looking for something that's not too little, not too much, but just right. So instead of going completely flat or having quote unquote too little, having a full reconstruction or too much, something that can be just right is in the middle, where the patients use their own skin that's left from the inferior pole of the breast to form the a small breast shape that's just using their own tissue and doesn't involve a very large surgery. So here you can see on the left and on the right what that might look like for a patient where they just preserve their own skin, and that helps to form the shape of a breast after. Okay. Moving on now, we'll talk about some risks related to surgery. When we think about risks of surgery, there's both immediate risk and delayed risks of surgery. Some of the immediate risks of surgery can be inadequate flap perfusion or skin complications. So what we're looking at here in C, B, C, and D is where the skin doesn't have sufficient blood flow to it, and so ultimately it dies. And in this case, if there's an implant or a tissue expander here, it would have to be removed typically, and the skin would need to be removed as well. You can also have loss of the nipple areolar complex. So as I was describing before, from an oncologic standpoint, we want to get very close to the nipple to make sure that we're not leaving residual tissue there. At the same time, we need the blood supply to the nipple to be robust so that it doesn't undergo necrosis. It tends to be the most sensitive area of all of the skin flap. There's also risk for need for additional surgery for any of these complications that we see. Risk of seroma, hematoma, surgical site infections, which again, if we were to see something like this, often the tissue expander or implant would need to be removed. And then they would undergo reconstruction at a later time. Wound dehiscence can occur. So you can see here where the implant that's there is starting to peek out. In this case, the implant would also need to be removed. Patients can experience blood clots after surgery. And there's also the risk of occult cancer diagnosis. So in this study, they looked at women who underwent risk-reducing mastectomy. About 80% of women in the study had an MRI preoperatively. But despite that, there was about a 1 to 3% risk of occult cancer diagnosis at the time of risk-reducing mastectomy. Long term, we can see things like poor cosmetic outcomes. So in this photo, the patient has capsular contracture, where the capsule or the tissue that forms around the implant itself becomes sort of scarred and tight, and then it causes the implant to ride up higher on the chest here, and can also be associated with pain. We can see something called an animation deformity. So we tend to see this in women who have the implant placed behind the pec muscle. So I'll just show a video of what that looks like. So you can see here that as she's moving, you'll see the implants sort of moving here up and out, and then she'll move to the side, and you'll see how it's sort of moving to the side as well. You can see how the implant moves to the side when she's retracting her pec muscle. You can also see rippling of the implant when it's placed in front of the pec muscle. So you can see here how the implant itself is just moving with gravity, and how that rippling occurs. And so here also you can see this sort of steep demarcation between the implant and her chest wall. So something like fat grafting may be helpful in this situation. And then another major issue is loss of sensation. So there was an article in the New York Times in 2017. It said, after mastectomies, an unexpected blow, numb new breasts. And I thought this was really moving. They said, while Miss McCree's rebuilt chest may resemble natural breasts, it is now completely numb. Her nipples lack any feeling. She cannot sense the slightest touch of her breasts, perceive warmth or cold, feel an itch if she has a rash, or pain if she bangs into a door. And no one warned her. I can't even feel it when my kids hug me, said Miss McCree. So I think this really highlights, one, the impact on quality of life after these types of procedures, and two, the importance of counseling, of what patients should expect after mastectomy. So this is something that as surgeons we're working on. We're now trying to perform more sensation-sparing mastectomies, although these are still relatively experimental. So what we do during these surgeries is preserve the lateral intercostal nerves that innervate the breast, as well as preserving nerves that innervate the nipple. And then nerve grafting can be performed to connect the two essentially, and help to re-innervate the nipple and preserve sensation to the breast and the chest wall. Um, and what's found is that usually the worst, the most loss of sensation occurs immediately after surgery, but that it is possible to recover a lot of that sensation in various parts of the breast after surgery with these types of procedures. In contrast to loss of sensation, some women can also have persistent pain after surgery. And that can be anywhere from 20 to 68% of patients that experience persistent breast pain. So they can either have burning, tingling, or numbness in the chest wall, sharp and shooting pain where they had surgery, numbness or shooting pain or swelling underneath their arm, or limited shoulder or arm movement. A lot of these patients will also end up needing additional surgery for things like capsular contracture, implant malposition, breastosis, or fat grafting. So anywhere from 2 and 5 women undergo elective revisions after this type of surgery. 3 and 5 undergo elective revisions if they have a complication. And then 2 and 5 women who have immediate implant-based reconstruction undergo revisions to improve cosmesis. So sometimes we'll have women who say, I want to just go straight from my mastectomy to have an implant piece so I don't have to have surgery again. And we know that a lot of the time, these women will still end up having additional surgery. So it's just important, again, for counseling. We can also see something called fat necrosis after surgery. This can happen both after mastectomy and we often commonly see it after fat grafting. It can be very concerning for patients because it feels like a lump in the breast and it shows up like a lump on imaging. It tends to look like a benign lump on imaging, but it can still be very concerning for patients who are their only real way of screening for cancer at this point is going to be with physical exam. And so you can imagine feeling a lump would be terrifying. Another thing that we need to discuss with patients is their family history and the residual breast cancer risk with age and life expectancy. So sometimes patients will be diagnosed with a BRCA pathogenic variant after an ovarian cancer diagnosis, say in their 50s or 60s, for example. And so someone who's coming to me to discuss risk reducing surgery in their 50s or 60s has a much lower residual lifetime breast cancer risk than someone who's coming to me in their 20s. And so it's important when we're weighing risks and benefits of surgery to say, what does that residual lifetime risk look like? Is surgery something that you want to pursue knowing what your residual lifetime risk is? And then in thinking about family history, we know that the BRCA genes have variable penetrance and that not everyone who has a BRCA pathogenic variant will develop breast cancer. It's not 100% penetrance. So it's about 70% penetrance. And based off of that, knowing the family history can help to sort of estimate what the penetrance in that particular family for that particular gene might be. So I had one patient who I think about often who was diagnosed with colon cancer actually in her 40s. And then in her 60s or 70s, her colorectal surgeon recommended that she get genetic testing or have updated genetic testing. And it was at that point that she was diagnosed with a BRCA gene. And she had no family history of breast cancer, no issue of breast cancer whatsoever. And she was actually a really terrible surgical candidate, but came to me to talk about risk reducing breast surgery. And I said, based off of your family history, I don't know that this really makes sense for you. But we did end up talking about risk reducing medication, and she decided to go that route instead. The last thing that we need to talk about when we're counseling patients are the psychosocial and quality of life aspects of risk reducing mastectomy. We know that patients with hereditary breast and ovarian cancer predisposition are at risk for heightened emotional distress for several reasons. One can be just a high threat, so high threat of cancer. High uncertainty, they don't know what's going to happen, if they're going to develop cancer or when that might happen. They're receiving large amounts of complex information, especially with the new diagnosis. They may have multiple experience of illness or loss in their families. They may also be making multiple decisions. So if we are thinking about someone who is at an age where they'd be thinking about risk reducing mastectomy, risk reducing bilateral salpingo-oophorectomy, family planning, whether they want to undergo IVF or pre-implantation genetic testing, testing for their family members. There can be a lot of things that they're balancing at once. And then when we start talking about all of these different surgical options, it can just be very overwhelming. Um, there's also a lot of demands from risk management. So if we think about even just patients who decide to undergo surveillance, it can be quite taxing for patients to come for imaging twice a year, especially if that involves subsequent diagnostic imaging, biopsies. It can just be a lot, both time-wise and emotionally. Um, and then again, it's important to think about how this impacts both the patient and then their family. So not only the family's risk of cancer, but then how that particular patient, if they're undergoing surgery, how that will affect their family. A lot of times, these are younger women with younger kids um, who are deciding to undergo surgery, and so it's important to balance what their responsibilities are and priorities are at home compared with what their surgical desires are. In general, though, we know that patients who undergo risk-reducing mastectomy are generally satisfied with their decision. Those who are dissatisfied, it's primarily related to cosmetic outcome. In general, patients report decreases in worry about breast cancer. And another important thing to talk about in general is that risk-reducing mastectomy has been associated with negative impacts on body image, feelings of femininity, and sexuality. And so that's where things like nipple preservation and like sensation preservation are really are a major focus. After surgery for these patients, we typically recommend an annual clinical exam. Again, the risk of breast cancer is not zero after risk reducing surgery. Those who develop breast cancer can either happen or it has been shown to happen within the mastectomy flap. There's been cancer that's developed in the axilla or in the armpit of these patients. And then some patients have also unfortunately presented with distant metastatic disease even after risk reducing surgery with a negative mastectomy or negative pathology at the time of mastectomy. Um, in general, we don't recommend imaging for these patients, although some facilities will get screening mammogram in women with autologous reconstruction or flap-based reconstruction. Um, if there's any concerns ever, then of course diagnostic imaging would be appropriate. And it's always important just to review and stay up to date on the most recent NCCN guidelines. I would be happy to take any questions at this point.
Well, thank you, Dr. Chichura, for a great talk on that. Great introduction to all of this. It's something we don't talk about, think about a whole lot. So I appreciate bringing attention to it. And I shared with you this hit home for me because I had my risk reducing mastectomy 13 years ago, almost to the day,
Mhm.
because I have BRCA1. So definitely a powerful topic for me. So I did have a couple of questions for you. I'll open it up to the floor and we can have all the discussion about this. I was curious. So I see a lot of patients in the cancer risk clinic who have already had
Mhm.
genetic testing, but may still have a significant family history of breast cancer. And while getting those other family members who are affected with cancer tested, they're still at an elevated risk. So at what level, I know it's not really defined very well, but at what level of risk, and I usually use the Tyrer-Cuzick risk model, um, do you suggest patients consider a risk-reducing mastectomy?
So in general, for this sort of situation, it's tricky.
Yeah.
The NCCN guidelines say that it can be considered for compelling family history, but there's no definition of what compelling family history is. So I think it's a little bit vague, and it's um, at that point, I think it's best driven by the patient. So in general, when we look at or think about things like decision regret, there's a higher decision regret in patients who had the conversation for risk reducing mastectomy initiated by the physician as opposed to the patient. So in that sort of situation, I would want it to be more patient driven, that it's something that they're thinking about and they're very motivated to do. Um, in general, those patients should still be counseled about risk reducing medications. And then if it's something that they're interested in and they're asking about, then I would be open to discussing. But there's not like a particular cutoff that I would have that I would say, we have to hit X% on Tyrer-Cuzick to qualify for this. It would just be an individual discussion with the patient and what their goals are and their particular family history.
Yeah, there's multiple factors that go into that. Yeah. Yeah.
Mm-hmm.
That. Does anyone have any questions from the audience? Speak up now. Raise your hand. Anyone? There's a bunch of folks here. No one has any questions? I can keep asking all day. Oh, Samantha Redmond says her mic isn't working. If you have a younger female who has a BRCA mutation, what age do you recommend they start considering prophylactic mastectomy? Like a woman who's in her 20s.
So yeah, again, very dependent on the particular situation. So, one, what age were their family members diagnosed with breast cancer? Um, if they have someone, if their mom or someone was diagnosed in their 50s as opposed to having someone in their family diagnosed in their 20s, that's a different conversation. And then also knowing what their reproductive plans are. Do they plan on having kids? Are they interested in breastfeeding? Are all things that are important to consider. So, generally speaking, there's no hard cutoff, but probably wouldn't really strongly think about it until age 25. But again, it's very variable depending on the patient, their particular situation. I've certainly seen patients younger than that with BRCA pathogenic variants who have developed cancer.
Mhm. Yeah, what's the youngest that you have performed a surgery?
I think I saw someone in their like who's 21 or 22, but she had cancer.
Oh, wow. Yeah. I
Yeah.
had mine, Samantha, too, at 28. So, yeah,
Oh
but
my gosh.
I talked to some
Yeah.
25, 26-year-olds about
Yeah.
the potential options, the screening versus surgery all the time.
Hmm.
So, yeah,
Yeah.
yeah. And then as far as the screening post mastectomy, if you have you said with an autologous reconstruction, continued
Hmm.
mammograms, do you still do those yearly then in that population?
Yeah.
Yeah.
Yeah, that was at least our practice at Cleveland Clinic, which again, I don't know necessarily lines up with the American College of Radiology recommendations, but it's not unreasonable to get it if the patient's very motivated to get it.
Yeah.
Um, but again, I think physical exam would be sort of our gold standard there. The other thing that should be just sort of on everyone's radar is for patients who have silicone-based implants that the FDA recommends screening for asymptomatic rupture of the implant itself, not necessarily for cancer, but just for implant integrity, about 5 to 6 years after they were placed initially, and then every 1 to 2 years after that. So that can either be with an MRI or with ultrasound.
Hmm. Yeah, that's one I'm always a little wobbly on. Um,
Mhm.
so
Yeah.
it's a tough recommendation to really sell. Um, yeah, that's interesting. Does anyone else have any other questions before I ask all my questions? Because this is definitely an area I'm very interested in. Just to, let's see, Amy says thank you. Yes. So yeah, I think you did explain this, but just to again
Mhm.
reiterate and to talk about again, you said the risk reducing mastectomy only reduces the risk by 90%, and that's from the 70%, 90% of that decreased by doing the wrist
Correct.
mastectomy. So, what was my question? Oh, menopause. Um, why is there still risk? What leads to
Mhm.
that continued risk of about 5, 6%?
Yeah. So, I mean, ideally, as surgeons, we'd be able to get every single last breast cell when we do these surgeries, but just collectively, we're not able to do that. It's a really fine balance between removing as much breast tissue as possible, but also keeping those skin flaps healthy. And so the goal is to be right in that perfect plane where you're removing every single last breast cell and just leaving behind the fat and the blood vessels that supply the skin. But even those who have like a simple mastectomy, do not have any reconstruction, they can still develop breast cancer. So it's just there's a cell here or there, and that's all it takes.
Hmm. Yeah, it's kind of like the intraperitoneal implants for ovarian cancer too.
Hmm.
It's just we can't possibly do everything, right? And get
Hmm.
everything. And it's
Yeah.
not a situation where there's like a chemo to use in people
Hmm.
without cancer.
Yeah.
Um, I wanted to ask you about the necrosis of
Hmm.
being able, because that's striking. That's like a significant, like that's on the surface as people like see that, there's many
Yeah.
psychological
Hmm.
effects, but if you look at your breast and that's happening, that's
Yeah.
gotta freak you out. So,
Hmm.
you ever used or had patients go to hyperbaric oxygen to treat a necrotic nipple?
I have not. Probably a better question for a plastic surgeon. One of my mentors, her mantra was always that the nipples want to live, which I think is true. So even if we do see some focal necrosis of the nipple, like a lot of time it's able to recover. We'll put silver nitrate on it, and it's able to generally recover more surprisingly than you think it would. That larger like flap necrosis that I showed, that's not going to recover on its own, but some
Yeah.
of that more focal nipple necrosis can actually recover. Um, but I personally have not referred patients to hyperbaric oxygen, but would be a good question for a plastic surgeon.
Yeah, that would be interesting. I'm not sure. I'm trying to think. I don't know if anyone here would know this if we have a hyperbaric chamber at UIC. My sister did that at Cedars, um,
Oh, okay.
approximately 6 months prior to me having my surgery. So
Oh,
because she
wow.
had some necrosis. Uh, so, but yeah. And can you speak a little bit to, I know in the breast cancer surgery and especially
Mhm.
risk reducing mastectomies and the reconstruction, like the pendulum always swings, right?
Mhm.
Like when I would went through this and had counseling, it was a little bit different. And so the guidelines and the recommendations change over time, right?
Mhm.
And
Absolutely.
yeah, can you talk a little bit about that? How like our practice has changed over the past like
Yeah.
10 years? Do you know back
So
to?
I think yeah, in terms of surgery, how things have changed, one major thing that's changed in terms of reconstruction is that implants were primarily placed retropectorally or behind the pec muscle. And now, for the most part, a lot of plastic surgeons are placing them in front of the pec muscle. So that changes some of the postoperative complications. Things like the animation deformity can affect pain postoperatively. But also, when we're thinking about looking for recurrence or for a new cancer diagnosis, if you have an implant between the skin and the chest wall, could there possibly be something that develops behind the implant or behind the tissue that's there? Like absolutely. So that's a concern that some surgeons have raised, and I don't know that we have a good answer to that right now, although that seems to be the practice that plastic surgery is moving in.
Mhm.
Another big change between 10, 15 years ago and now is that there's a lot more skin and nipple sparing mastectomies being performed than there were previously. I think it's gained more acceptance in general as just a surgical approach for cancer patients as well as in prophylactic surgery. And then the other really big thing we're seeing is the sensation sparing mastectomies. And I think that's one of the biggest changes over the last 10 years that those are starting to be offered more and more for patients, especially those undergoing prophylactic surgery, where we're not as concerned about oncologic margins, that we're able to preserve more of those nerves laterally to keep sensation to the breast and the chest wall.
Cool. Yeah, there's a lot more
Mhm.
history and everything to this too
Yeah.
that you don't
Hmm.
realize on the surface. And yeah, I have to say, post
Hmm.
mastectomy with implant reconstruction under the muscle, it was
Hmm.
weird getting used to it. So the sensations are
Yeah.
just so different. And if I'd had the same thing today, like there's so many more options and
Hmm.
discussions.
Yeah.
Do you
Yeah.
ever
And
use?
then the other big thing would be sort of the more acceptance of one of doing a reduction and then a skin and nipple sparing mastectomy, more emphasis on preserving the nipple for these patients. And then there's also some people pioneering sort of um, sometimes referred to as a Goldilocks mastectomy, which is also confusing, but basically keeping the nipple, doing a reduction at the same time that you're putting in a tissue expander. So, sort of that reduction pattern, repositioning the nipple and
Mhm.
doing a mastectomy at the same time. There's a very high risk of complications with that currently.
I know that can be a factor too when women have breastfed several babies, like the
Hmm.
architecture of the breast has,
Exactly.
because unfortunately my three sisters all have BRCA. So two of them
Oh
breastfed
gosh.
children. And so it was
Hmm.
a different thing for them. Um, do
Hmm.
you ever use like intraoperatively? So, do you personally do any of the sensation sparing? Do you like pay attention to that and the nerves
Hmm.
when you're in there?
Yeah. Yeah, I do.
Is there
Yeah.
any special tool or something like a mini EMG or something that you can use intraoperatively?
No,
It's just,
not necessarily. You just go based off of anatomy, where you expect it to be, and then just careful dissection to preserve it. Um, but it is something that been having pretty good success with. Um, and it's nice to be able to offer it to patients, and then usually work in for the if I were to use a nerve graft, that would be with a plastic surgeon who would be performing that.
sure. Yeah.
Mhm.
Yeah, I know I've also heard of like and seen them using an ultrasound intraoperatively to look at that blood flow into the nipple in particular to make sure things are preserved. So is that
Mhm.
something you've seen used with plastic surgeons too?
I mean, not so much ultrasound as ICG. So they'll inject fluorescent dye basically into the veins. And then you can like look at it in real time, perfusing the breast or into the artery, look at it in real time, perfusing into the breast and see where the blood flow is. Is the
Uh,
blood flow coming in and moving out quickly, or is it sort of congested? And you can use that to predict what, if there's going to be complications with the flap postoperatively. So some plastic surgeons will do that routinely. Before they decide to put in implants or a tissue expander, if they're concerned about the flap, they'll say, "I'm not going to put in anything foreign. We're just going to let this heal, and then we can come back and do reconstruction later." Other plastic surgeons, especially as they, if they've worked with their breast surgeon for a long time and they're very comfortable and they know sort of what to expect with outcomes, and then they're less inclined to do that.
right, right. Yeah, well, I think that's most of my question. Anyone else? Comments, questions? We just got some ITHA. Well, thank you very much, Dr. Chichura.
Of
We're
course. Thank
excited
you
to
for
have
having me.
you. It was a
Yeah.
great uh fortune. I don't know. I can't find the word. That's the other part of this is the risk reducing oophorectomy.
Yes.
40-year-old menopause. anyway.
Yes.
So thank you so much. And everyone's
You're
just
welcome.
thank you. And I'll get this posted. You can join us in April for the next lecture series. It'll be with Yami Molina on patient engagement and patient and community engagement. So I hope to see all of you there. Thank you.
Thank you.
Have a good one. Bye.
Bye, you too.